Good morning or good afternoon to every participant and welcome to this surgical lecture hosted by Delacroix-Chevalier. Thank you very much to each of you for attending this webinar. Today's subject deals with a very interesting topic in the thoracic surgery field. Do you perform major thoracoscopic procedures using only one or multiple ports? And why do you think your approach is the best approach? This session will be divided in three different parts. The first 20 minutes will be dedicated to providing elements in favor of uniportal VATs. The next 20 minutes will address multiple ports. And the last 20 minutes will be a questions and answers session directed by the moderator. Do not hesitate to ask your questions using the live chats available on the right side of your screen. We'll try to address most of them. Well, before we start, I'm glad to introduce the three surgeons who are going to speak today. Our first speaker is Dr. Alan Siwe from Hong Kong. Dr. Siwe studied in different countries, including England and Scotland, and is today practicing at Gleneagles Hong Kong hospitals. He is an internationally recognized advocate of next-generation VATS techniques, especially uniportal chest surgery. His work in thoracic surgery has won multiple awards, including from the most prestigious associations like ESTS or ISMIX. He has authored or co-authored more than 200 articles. Good evening, Dr. Siwe, and thank you very much for being with us today.
Thank you for having me.
Our second speaker is Dr. Dominique Gossot from Paris, France. Dr. Gossot is a senior consultant in the thoracic department at Institut Mutualiste Montsouris, Paris, where he was the head of department until December 2020. He is a member of the main thoracic associations, including STS, EACTS, and ESTS. He is the organizer of the Sublobar Resection for Lung Cancer Congress, with already 2 editions, and the 3rd edition will take place in Tokyo this year. He has also published 170 articles and 2 different books. Good afternoon, Dr. Gossot, and thank you very much for being with us as well. Our moderator is Dr. Joel Dunning from Middlesbrough, United Kingdom. He will lead the questions and answers session. Dr. Dunning is a thoracic surgeon working in Department of Cardiothoracic Surgery at James Cook University Hospital in Middlesbrough. He is the director and founder of Cardiothoracic Advanced Life Support, and also chairman of STS Guidelines Committee on Resuscitation after Cardiac Surgery. He is CTSNet Associate Editor since 2012 and Annals of Cardiothoracic Surgery Editorial Board member. And obviously, he has authored or co-authored many publications and articles. Good afternoon, Dr. Dunning, and thank you very much for being with us.
Good afternoon, and good afternoon, everybody. Thank you very much for inviting me here, and welcome to Port Wars. So we're absolutely delighted to be having 2 giants in our specialty. We have the amazing Dominique Gossot, who just set up just this phenomenal segmentectomy conference. We're so excited to be going to the next segmentectomy conference. Obviously, JCOG has now come out and reported the amazing steamroller future, which is going to be segmentectomy. But we've learned so much from Dominic with all his amazing videos and his careful techniques over many, many years. So I'm really looking forward to hearing what Dominic has to say. But first, we have Alan. This is not even your first webinar today. You are everywhere. COVID has meant you can travel the world in just seconds. We heard earlier from you on GGOs. We're hearing from you in our Society of Cardiothoracic Surgery meeting very shortly. You've been at the AATS, and today we're absolutely delighted to have another of your amazing talks. You do them with such good humor, such positivity. I'm really looking forward to hearing from you today. So without further ado, let's get cracking. I encourage everybody to chuck a whole load of questions on the YouTube channel. I can see them. I'll ask them for you. Anything you wondered, we don't mind. You can even ask about Alan's Ferrari if you like. We've got 20 minutes at the end, so get cracking with those questions. If you don't, I'm just going to ask some absolute stinker questions myself. So let's get cracking. Let's hear from Alan Seho, and he will advocate for the wonderful uniportal VATS lobectomy.
Well, warm greetings from Hong Kong. I'd like to thank Dr. Dominique Gossot and Delacroix-Chevalier for organizing this interesting debate. Now, when I was first telling my friends that I'm engaged in this debate, I was asked two questions. The first was, Alan, this debate is meaningless. It doesn't really matter whether you use one port or multiple ports. And to a certain degree, I agree with that. The idea of this debate is not to find a winner as such, which should everybody do. But the fact that we're having this debate is meant to focus all of you to concentrate on the factors that are important to our patients and also to us as surgeons. What are the details in our technique that make a difference? And even when we're considering how many ports we're using, we should question what makes a difference in minimally invasive surgery? How can we make little incremental improvements to make outcomes better for our patients? The other question I get asked a lot, especially in the context of this debate, is, Alan, this debate has been going on for many years. We've heard all of this before. And indeed, since my good friend, Diego Gonzalez Rivas, my brother, invented this technique for lobectomy almost 9-10 years ago, we've had countless debates. But here's the key thing today, why this debate is slightly different. Over the last 8, 9, 10 years, as we've been debating this topic, we've always approached it from the perspective of somebody who's already doing conventional 3 or 4 port VATs. And we're questioning why we should move on to something like uniportal. And so we as uniportal surgeons have always been on the defensive, trying to persuade everybody else that, oh, uniportal is better. And when you fail to demonstrate that uniportal is so-called better, you're going to lose that debate. It's very difficult. But here's the thing. Today is not 5 years ago or 8 years ago. Today, the situation is different because today, most of us are already well exposed to the uniportal VATS technique. In this survey done a few years ago in ESTS, notice how many people in Europe are already performing uniportal VATS. So the debate is slightly different now. We're not talking to a lot of people who are only versed in multiportal VATS trying to persuade you all to go to uniportal. Today, I think it's a more even playing field. There are many people doing uniportal as well as multiportal. And so therefore, today, what I'm going to be exploring with you is something slightly different. And that is, if I am already familiar with uniportal VATs, what is the point of adding extra ports and going to multiportal VATs? Can you convince me to use those 2 extra ports? It's a bit like convincing a cyclist, a master cyclist who's well used to using 2 wheels, to suddenly add on 2 more training wheels. And you're telling them that these training wheels would suddenly make your cycling a lot better? How does that happen? And so I'm going to try and test this hypothesis of the magical extra ports. If I'm doing uniportal VATs, does suddenly adding 2 or 3 extra ports create some magic in my surgery that will make the surgery suddenly so much better? Can you convince me of that? Well, I'm going to try and make this argument and test this hypothesis in 4 different categories. The first one is, does adding extra ports make your surgery safer? Are you adding safety by creating extra ports? Well, let's have a look at this. Now, this is a paper that you may or may not have read. I published this a couple of years ago in the Annals, and we did a systematic review of the papers at that time. And you can see even a few years ago that the total published cases of anatomical resections using uniportal technique numbered well over 1,000. So over 1,000 cases. And what was the mortality and morbidity amongst all these published patients in the series over the years? Well, you can see for yourself. Very low mortality and reasonable morbidity. That's not too bad at all. Now, the question is, if I'm going to add these magical ports, does that give me more safety than these figures? And let's have a look. This is a series published using the SEER database, so a very large database. Again, we're talking in multiportal VATs over 1,000 cases, so a similar number of cases. And look at those mortality figures. Are they any better than what we just saw with uniportal VATs? No. Now, this is, of course, the SEER database, and people criticize it. Let's move on to some more recent studies. For example, this is from our good friend, Alex Brunelli, who's now working in Leeds. And again, in the hands of a master VAT surgeon like Brunelli, what are his results like? So you're still talking about mortality figures of about 1.92%. 90-day mortality rate was 2.5%. So even in the hands of a master multiport VATS surgeon, you're not really adding that much safety on top of what you can achieve with uniportal VATS. Now, this is the latest meta-analysis looking at this subject. This is just from last year. And again, if you look at all these parameters in terms of things like blood loss, length of stay, drainage duration, in none of these categories is the p-value significant. So that means that adding these multiple extra ports adds nothing in terms of safety over a uniportal VATS. So magical extra ports for safety? Sorry, it doesn't really work out that way. Well, maybe adding these magical extra ports gives you better perioperative outcomes. Maybe patients suddenly miraculously have a better surgical experience. Well, let's have a look at this. Now, the first systematic review I did on this was a simple one back in 2016. And at that time, the number of papers comparing uniportal and multiportal VATs, well, there weren't that many. Now, you can see in green are the papers and the categories where we found that uniportal VATs was maybe a little bit better. In red are the papers and categories saying multiportal was better. Well, yeah, there was a scattering on both sides, maybe a bit more in favor of uniportal, but it wasn't very conclusive. Now, this is 2016. 2019, again, this is my earlier paper in the annals. Again, there are now more papers looking and comparing the two approaches. So again, you're looking at the red boxes here, which says multiportal VATS is better, versus the green boxes here, which says uniportal VATS is better. And you can see in the 3 years intervening, the number of papers and categories being shown to be favorable for uniportal VATS is now increasing. There's still not many papers that show any real advantage for multiportal VATS. Now that's 2019. At that point, even though there's a swinging in favor of uniportal VATS, I was still conservative. And I said that it's still premature to say that uniportal VATS was better than multiportal VATS. But the flip side of the coin is we still haven't proven that multiportal VATS is better than uniportal VATS either. Now, the latest iteration of this comparison, this systematic review table that I've been collecting over years, this I published in Mark Ferguson's book just last year. So now we updated all these comparative studies, and this is the final thing. Now, again, red represents categories where multiportal VATS was found to be better. Blue shows where uniportal VATS is better. Now, even if you just scan this table very quickly, you will see that there are many more boxes of blue than red. And if you go down each of these columns, are there any columns here where red outnumbers blue, where multiportal VATS is better than uniportal? No, I'm afraid not. In fact, in one of these columns, pain, uniportal VATS consistently outperforms multiportal VATS. Now, I know that pain, many people say it's not that important, and you wouldn't go to uniportal VATS just because it causes less pain, would you? Well, maybe. But on the other hand, is there anything on this table that would convince a uniportal VATS surgeon that doing multiple port VATS is better? And there isn't. Now, this latest meta-analysis, this is just earlier this year, published by our friends from Greece. And again, if you look in terms of total complications, in terms of pain score, the visual analog score, length of stay, all these parameters of perioperative outcomes, all of them are now significantly found on meta-analyses to be in favor of uniportal VATS. So even if you don't think uniportal VATS is superior, which this study does, even if you think it's equal, you certainly cannot prove that multiportal VATS is any better than uniportal. So in terms of this extra ports being magical, no, they're not in terms of giving you a better perioperative experience. So here comes the most important point for some is maybe by making extra ports, doing multiport VATS, I'm improving survival of cancer patients. Now, this is the key, isn't it? This is the most important point. Now, in terms of survival, we look at in terms of cancer cure effectiveness, we look at two things: the extent of lymph node dissection and also the actual survival. So what do these studies, the published studies, say about this? Now let's go back to my my previous table here. So again, if you scan this whole table, there is really only this column that addresses this point, and that's the lymph node dissected. And again, most of the papers that have been published comparing the two approaches show no difference. No difference. In fact, there are one or two papers, or three actually here, that show uniportal VATS might be superior than multiportal VATS. But none of the papers show that multiportal VATS gives you better lymph node dissection. More recently, I think our colleagues at ISMIX did a systematic review as well, and they also came to the same conclusions. In terms of lymph nodes dissected and the incidence of nodal upstaging, multiport VATS was not superior to uniportal VATS. In terms of survival, disease-free survival at 3 years, again, if you look at the p-value, there was no difference in overall effect, no significant benefit if you add those so-called magical extra ports. Now, this, again, is that latest meta-analysis published earlier this year. And if you look here on the bottom, again, using these same two parameters in the most updated meta-analysis we have to date, no superiority for multiportal VATS in terms of resected lymph nodes or median survival. So I'm very sorry to say that these extra ports do not improve survival. It's not a reason for me to go from uniportal to multiportal VATS. So the last argument a lot of the multiport VATS colleagues like to use is that, well, uniportal VATS is difficult. Why make a simple operation more difficult by just forcibly going to one port? So is using extra ports a way of making your whole operation simply easier on yourself? Well, is it? Well, let's again go back to the evidence. Now, this is a paper from last year, very interesting, a learning curve experience of someone going from thoracotomy to VATS, but to uniportal VATS. And what was the learning curve experience like? Well, simply put, the headline figure is about 140 lobectomies later, this person managed to master uniportal VATS lobectomy. 140, is that a lot? Most importantly, how does that compare to multiport VATS? So let's look at here. This is almost exactly the same kind of study, but looking at transitioning from a thoracotomy to multiport VATS lobectomy. And if you look at that graph, surprisingly or not, that's exactly what we saw just now in that earlier graph of uniportal. This surgeon again found that the learning curve was about 140 cases, as you can see there on the right. So it's uniportal VATS is not that much different from multiportal VATS in terms of the transition from open to minimally invasive surgery. It's not more difficult to learn. In terms of moving from multiport VATS to uniportal VATS, I've given this talk before, it's actually not that difficult either. If you're starting off from 3-port VATS, you just go to 2-port VATS by sharing your instruments through a single utility port, and then you move that camera port into the same port, and suddenly you're quickly into uniportal VATS. It's not that difficult. So in terms of transitioning from 3 to single port, what's the experience like? So this is a different kind of learning curve. This is the learning curve from multiport to uniportal VATS. And you can see here roughly the learning curve is only about 30, 40 cases. It's not that much in all of our experience. It's quite easy to go from multiple port VATS to single port. And in fact, another way of looking at this is the course that Diego and I have been running in Shanghai for a number of years, where we invited a lot of surgeons from around the world, most of whom are already familiar with multiport VATS, and they go for just 2 weeks to Shanghai, mostly to learn uniportal VATS. And in just 2 weeks alone, you can see here, significantly, they've gone from multiple port VATS to single port after just a 2-week learning experience. So real life experience shows you that this transition is not that difficult. Uniportal VATS is not that difficult to learn at all. And as you master this technique, you can do any kind of operation that you would do with multiport VATS using uniportal. So whether you're talking about simple segmentectomies, whether you're talking about more complex resections, even sleeve lobectomies, anybody can do it. I mean, if I can do it in these videos, I'm sure anybody here in the audience can do the same. It's more of a sort of a mental barrier than a physical barrier when actually taking up uniportal VATS. It's not that difficult. In fact, here's the point is, if you're doing uniportal VATS, you can always move backwards if you get into any trouble. You can go from one port, and if you're getting into trouble, you can make another port, or maybe another port after that if you want to. But if you're already starting off with 3 ports and you suddenly find this operation very easy, you cannot, in the middle of an operation, suddenly make one of these ports disappear. So starting off with uniportal VATS, why not? So having considered all of these factors, what's our conclusion? Well, I'm sad to say that extra ports, this hypothesis that extra ports are magical, is simply false. It doesn't increase your safety. It doesn't make your outcomes any better. It doesn't improve the oncological outcomes or survival. And it doesn't make your mastery of minimally invasive surgery any better. These extra ports are not magical. So why are you doing it? But if you're not convinced by what I say, maybe you'll be convinced by what your patient says. Because increasingly patients, they know about uniportal VATS, and they will sit in your office with lung cancer. And when you say, oh, I'm sorry, I'm not going to do uniportal VATS, I'm going to make a few extra holes, they're going to be asking you, doctor, why are you making those extra holes on my body? And I'm sorry to say that you cannot tell these patients that, oh, these extra holes are magical. They're going to make the surgery so much better. That would be a lie, because there's no evidence showing that. And for this reason, I think uniportal is probably the way we should be going today. I rest my case. Thank you very much.
Absolutely fantastic, Alan, there. Well done. Brilliant. Magical Alan, as we're going to call him.
Thank you.
That vision of it. So that was brilliant. I would definitely say to everybody that the Shanghai Pulmonary Center is amazing. Their courses are phenomenal. You don't just learn uniportal, you learn segmentectomy, extended resections. It's incredible. It's everybody should go there every year, really, shouldn't they? It's fantastic. So we will now move on to round 2 in the battle. We've got the phenomenal Dominique Gousseau. He has been doing absolutely immaculate, beautiful, high-quality surgery for so many years. He runs great courses. He's taught us a lot about segmentectomies and huge amounts. And Dominique's now going to give us the argument for what is most magical about those extra 2 ports.
So let's talk now on multi-port access after the talk of Ali. Here are my disclosures. So I've given conferences for Medtronic Company, Olympus, and I'm consultant for Delacroix-Chevalier. By the way, what I will do is a bit unusual, but I would like to take profit of this presentation to give a warm thank to the engineers of Delacroix-Chevalier, Lucy Bord and Thibaut Durieux, we have collaborated together to develop the instruments, and it was a great adventure. So thank you very much. So if you look at PubMed, there are many articles and works on this topic. Should we stay to multi-port thoracoscopic access or to uniportal? Every year, the number of publications is increasing. And this has pushed me to give some consideration about approaches in thoracoscopic surgery. What I think is that there is something more important than talking about uniportal or multiportal. I think what was really important is to switch from open chest surgery to closed chest surgery. This is the real breakthrough. And now that we are in closed chest surgery, is it important to work with a robot or without robot by, let's say, conventional thoracoscopy with one port, 2 or 3 ports or more ports? I don't think that's so much important. What is really important is not opening the chest, and I will not detail all the reasons that push us not to open the chest of our patients. So we have heard the talk of Alan and many arguments of the uniportal group are important to take into consideration. One is a bit surprising for me. It's the importance of cosmetics, and there is not a single article dealing with uniportal surgery without this kind of picture showing the incision and how many centimeters is this incision. Okay, we'll see maybe some differences. Of course, one may presume that when there are more ports, you have more pain. And I think there is no doubt that usually uniportal is not as painful as multiportal. And of course, if pain is less, probably the stay also is less. And this was demonstrated by this article, demonstrating that the frequency of hyperrhgia, hypoesthesia, and numbness was reduced in single incision thoracoscopy compared to complete VATS. Frankly speaking, I don't have so much doubt about this. One of the benefits of uniportal, at least coming from the surgeons who are doing uniportal, is the geometric aspect. And frankly speaking, this is very unclear to me. I have some difficulties in understanding the demonstration. And one of the weak point of this demonstration is that multiportal thoracoscopic surgery is presented like this with this classical triangulation, which is something we don't do. I mean, there is no classical triangulation in what we are doing in our institution. Here is the optic. Here are the two instruments. We are working in the back like this. So how can you demonstrate the benefits of uniportal? You can take into consideration the satisfaction of the patient, and you can rely on comparative studies. Well, talking about the satisfaction of the patient is almost impossible, as hopefully patients are usually operated only once. So in my experience, all the patients who are operated by thoracotomy, by uniportal, by multiportal, they are all very satisfied, because usually they had a cancer, and when they wake up, they don't have that cancer anymore. So generally speaking, they are satisfied. So I don't think this is something you can take into consideration. So you must rely on comparative studies. There are plenty of these studies. Usually they demonstrate either that the results are the same or that they are slightly superior with uniportal. The issue is that there are many biases that are not considered. One of the biases is that these studies are done in a center, and the center and the surgeons of this center have some experience. Is this experience important or not that important? And one aspect also plays a major role. It's the history of the center with regard to minimally invasive techniques. By that I mean that centers who have a large experience with, for instance, with the robot, they will have difficulties in performing thoracoscopic surgery. And the same for those who are very much experienced with thoracoscopy, they have difficulties in doing the robot. And the same for those who are experts in uniportal or experts in multiportal. So this is a barrier to take into consideration. And there are also some barriers related to the procedure. It's quite difficult to find in the articles some details. For instance, what is the exact length of the incision and the location of the incision? For instance, if you have a posterior port, it's usually more painful than an anterior port. What is the exact number of ports? Because you can presume that the more ports you have, the more pain the patient is experiencing. What is the type of optics you are using? It plays a role in the postoperative pain of the patient, because sometimes in the uniportal, you may be obliged to have some torquing of the optic that may cause some pressure on the incision and be a cause of pain. What is the diameter of the instruments? Are they conventional, let's say 10 millimeter or even bigger, or just 3 or 5 millimeters? We will see this aspect later on. And finally, what is the analgesia that is done on the patient? Is there an infiltration of the ports, a paravertebral catheter, and so on and so on? There is also a definition issue with what is uniportal and what is multiportal. This is considered as a multiportal. I would almost say this is a port and 2 thoracotomies. Same for this picture. So it has nothing to see with what we are doing in the department with 2 small incision. This brings me to this problem. What is exactly a port? If you have a 5 millimeter trocar and you consider the diameter of this trocar compared to the length of the intercostal space, you can understand that probably if you don't injure the intercostal nerve, the postoperative pain will be minimal, not to say inexistent. And this is even more true if you are operating with 3 millimeter instrument. And I've never seen a patient complaining of some pain at the site of insertion of these 3 millimeter instruments. You don't even see the scar of these instruments. So it's easy to understand, as this is mentioned in this very recent meta-analysis, that there is that the groups are extremely heterogeneous. And as mentioned in the conclusion of the paper, there are differences in technique and instruments among centers. So it's very difficult to have definite conclusions. And finally, as written by our friends Herbert de Calway or René Peterson, is it a real problem in lung cancer surgery? I'm not so sure. And I would agree with the conclusion of this recent paper that thoracic surgeons should pay more emphasis on providing high quality and personalized surgical care. So now, what are we doing in the department? So I would like to give you the standpoint of our department, which is based on optimal vision, no compromise with exposure, with the quality of exposure, and with the safety. So we are using a multi-port approach. And what is the reason? The reason is that exposure is a crucial point to have a nice operation. And I find this quote in a classical manual of thoracic surgery: to be well exposed is half of the success of a surgical procedure. And I will agree with that. And it's impressive how surgeons for years have tried to reach a good exposure, developing those kind of retractors, for instance. Also, I think that we surgeons, we have two hands, and this is very, very well utilized by the robots, the Da Vinci and the other robots that are coming on the market. And a couple of years ago, I was attending a conference of Bob Sarfolio, and he was saying that he was rediscovering the pleasure of open surgery because he had multi-port access with the robot. And as you see on this on this small video, we have also a bimanual surgery, while some surgeons performing uniportal surgery, as they say themselves, they are using their left hand mainly for grasping or for retracting the lung for exposure, which means that in many cases they are operating with just one hand. So I'm not saying that multiportal is much better than single port, and I'm quite confident that in the future, single port surgery will be the best option if you get this, and if we get this and that it works. So for the moment, we are at the early beginning of development of these instruments. For the moment, we don't have an efficient single port robot. So I still think that for conventional thoracoscopic surgery without a robot, multiportal probably is more efficient. So this is the ports we are using in the department. Some of the ports are only 3 millimeter, and we can even add an additional 3 millimeter ports when we are in trouble with exposure like this. So usually the surgeon is in the back of the patient for right side procedures, and in the front for left side. This is a matter of dominant hand, of course. Everyone can choose the side he prefers. Second principles, we are basing on optimal visions. Everyone has his own monitor to have a good vision throughout the procedure. And we try to have outstanding picture as accurate as possible. I think this is one of the minor issue with a single port, is that very frequently, because the scope is inserted directly through the incision in contact with the instruments, I noticed that frequently the vision is somewhat obscured by, for instance, blood drops and so on. We have various angles of visions thanks to a deflectable scope we are using, and when you get used with this scope, it's very difficult to work with a rigid scope. We have a stable image. For years we worked with a mechanical scope holder. Now for about 3 or 4 years we have this robotized motorized scope holder, and as you see, it's not that bulky, so there is a large room for the instruments on the patient. I was quite interested to see just 1 or 2 years ago that surgeons were discovering the interest of a mechanical or robotized scope holder, because this is something we are using for I'm afraid to say, 20 years. Keeping a clear image is also avoiding blood drops, which is, as you see, quite annoying. And so we have developed with Delacroix-Chevalier this very nice trocar where the blood drops are deflected. And frankly speaking, you can work during 2 hours or 3 hours without removing the scope from the patient. The optic we are using has also the big advantage of having a fog-free device at the tip, which works extremely well. This is also very convenient. So the third principle is to work with a dedicated instrumentation. And either the conventional instruments that some surgeons are still using and that are inserted through the utility incision, or the modified instruments like this on the right side of the slide, they are much too bulky for the accuracy that we need. So many years ago, we have worked with the laparoscopic instruments. This was also, there were also many drawbacks. It was not convenient at all. They are too long. The handle is not appropriate for thoracic surgery. And so there were many ergonomic problems. So after a couple of years of practicing surgery like this, I say, well, we have to move to totally different ergonomy. And this is why we have developed this range of instruments. One of the advantages also of these instruments is that they are not only very much ergonomics, but also very precise. And I think this is not the kind of vascular dissection you can easily do with other types of instruments. We are also, as I said, we are also using 3mm instruments. Before we were using this only for exposure, but now we have also a range of 3mm device. I find this in the literature. Of course, the less the diameter, the less pain, but I think that engineer will probably say that it's not realistic in terms of resistance of the shaft of the instrument to have that small instrument. Again, to show you that the damage to the intercostal space is very small. And if you want to add instruments, but not using ports, you can also use this kind of throw-off instruments that we are using quite frequently. This is especially interesting when you are working a long time on a single layer. For instance, here you are removing a bronchogenic cyst. It takes you, let's say, 1 hour, always on the same field. So you don't move your camera, you don't move your instruments, and you can retract the lung with one of two of these retractors. You have a thread that you can insert here at the basis of the retractor and pass the thread directly through the skin. This is another example. You have here this throw-off retractor that helps very much for exposure. You have also vascular bulldogs that you can release inside the chest cavity. Hopefully we are not using them so much, but I would say 1 or twice per month, we are happy to have these instruments in the operating room. You can also have dedicated instruments for exposure. This is something we have developed, what we call 3 legs retractor for exposing station 7 on the left side, which is sometimes a problem in some patients. So that enlarge the space for dissection. as you can see here. And now you can work through the legs of these instruments to remove the lymph node. Recently, we have also developed those kind of retractors to get around vessels or bronchi. This is quite convenient, especially for sublobar resections where you need to retract the vessels. I don't have an experience, well, I have a small experience with motorized curved instruments or deflectable instruments, but Joel has a much better experience. He has used several types of these instruments, and maybe he will comment on that, so I will not do it. The fourth principle is that we perform a full thoracoscopic approach without any access incision. So just I would like to comment briefly on the rationale of using or non-using a utility incision. So those who are using this access incision say that it permits to use conventional instruments, but we don't use these instruments. So we don't need a utility incision. And another argument is that if you have an access incision, that helps you to manage some problems that can occur during the procedure, like a hemorrhage. And incision is necessary anyway to retrieve the specimen. So this might be true for big lobes, but for some segments, it's not necessary at all. So with respect to the management of a complication when using a utility incision, what are the options? So you have a complication. If you have an access incision, you will be tempted by enlarging this incision. And we know that from time to time, it ends up by a true thoracotomy. This was demonstrated by this Japanese paper a couple of years ago, where the occurrence of a hemorrhage during the procedure end up in a mini thoracotomy, and this mini thoracotomy in a couple of cases were converted into a true thoracotomy, which means that the patient had the two incisions. So our philosophy is that we are working only with ports without utility incision, and if ever a complication occur, if you have some experience, the question you have is, I am able to manage this complication safely by thoracoscopy. Sometimes, yes. This is an example. So you had an hemorrhage, you compress with this gauze, you remove the packing, you see the origin of the hemorrhage, and you are able to deal with this by thoracoscopy. And if not, we prefer to do a conventional thoracotomy. It will be safer for the surgeon and maybe also safer for the coronaries of the surgeon. The fifth principle I will not detail because it's not really related to our topic and we don't have so much time. It's a Fisher-based approach as described by William Walker. So this is a type of surgery we are performing. So in conclusion, I let you read this conclusion of two papers. I think I fully agree with this. We should pay attention of providing high quality and personal surgical care. And in this paper from Tesi, that is ahead of prints in the Annals, I found this conclusion very pertinent. It's also prudent that we surgeons provide outstanding surgical techniques. Why? Because we have some competing treatments, and if we are able to provide outstanding surgical technique, by outstanding I mean very precise, I think we can stay very much competitive. And accuracy is, for me, a matter of image, instruments, and so far, waiting for single port robot, mainly multiple. Now, I would like to remember once again that maybe it's not that important, single port or multiple port. What is important is the safety of the patients, and that when the patient is operated on for lung cancer, he will be cured. Thank you very much for the attention, and probably we will have a good discussion now.
Wonderful. Thank you very much, Dominic. An outstanding talk. I think a really strong message that's come out from both of those speakers is that there's a huge emphasis on just really good quality surgery. We have thoracotomy on one side that I think we can all agree really is not good for the patient, and we do have SBRT, and we're there in the middle talking between BMWs and Mercedes. But just in the next 20 minutes, we're just going to ask a few little questions there, and maybe first to Alan. So we're on the chat line to Eric Lim this morning. He's done an amazing RCT, absolutely nailing that thoracotomy versus VATS. There's a proper difference. Shorter length of stay, better outcomes for patients, better safety, fewer complications. Nailed it. So my question to you is, if Eric said to you, Alan, tell me what randomized study I should do for the next 3 years, would you say to him, yep, let's do uniportal versus multiportal, or do you think there are other more important things we should concentrate on as a community?
That's a great question. Well, I certainly wouldn't spend any money on comparing uniportal and multiportal. It's purely academic interest. As we all agree, it's not that important. Even if you manage to find P is less than 0.05 in any category, the absolute difference is likely to be infinitesimal. It's not going to make any difference. The only thing about this debate is that we should all, as surgeons, question why we're doing each little step. Why we use how many ports? Does it really make a difference? For example, how many of us still use 2 chest drains after a lobectomy? I don't think anybody does. So if you find something that's redundant, don't do it. Now, going back to your original question, what randomized trial we should be doing? Well, I was talking to Eric earlier today, and he's already doing the one I would do. And that's a trial to look at the use of surgery as part of multimodality treatment for stage 4 lung cancer. Because if we're looking at uniportal versus multiportal, we're still debating within ourselves, within what we're already doing. I think we as surgeons at the cutting edge, we need to be pushing forwards, exploring where surgery can reach patients but where we couldn't reach before, and expand the range of patients we can treat. And if Eric's new trial actually can demonstrate that we can use VATS, uniportal or multiportal, in stage 4 disease, that's a whole different story.
Sorry, muted. The commonest problem in webinars. Yeah, I couldn't agree more. Absolutely. We should all get behind this amazing study. And I guess the message from his study is operating might get more technically difficult, which again is for us to technically debate. So if I maybe could come across to Dominique. Alan was so impressed by your talk that he's actually going to invite you for a year to Hong Kong. Who wouldn't want to have a year in wonderful Hong Kong? So my question to you is, if he did invite you for a year to Hong Kong, how would you approach that year? And really the question is it okay to have different surgeons doing different techniques in the department, or should a whole department do the same technique? What would you recommend when you go to Hong Kong in about 3 months' time?
Sure, no problem.
Oh, Dominic
yeah.
is so horrified by that concept that he has disappeared. Maybe he's getting on the plane actually straight away to come over to you. Maybe I'll go over to Alan and just ask you.
We're very safe at the moment.
I'm absolutely signed up to surgeons. I'd love to.
To answer your question, though.
No, but my question to you, Alan, is yes, we often say yes.
Yeah, you were saying that in the department, do people use different techniques? And absolutely, whether I'm in Hong Kong or in Shenzhen and Shanghai, all my colleagues, we use different techniques. And the beauty of that, and even going to other units around the world, is you get to see everybody's technique. And it's not necessary, as you know, Joel, it's not just to copy other people's technique, completely, but you see each little trick and each little way of doing things, and you just add bits to your own repertoire. I learned from your microlobectomy technique, for example, making that subxiphoid incision. I use that for my large thymomas nowadays to retrieve the specimen. So we all pick up little bits and bobs, and I think it's great to travel and learn. Not necessarily to buy the whole package, but to learn those individual modules of technique.
Yeah, I absolutely couldn't agree more. The one thing all surgeons should do should be to get out there, see other people's techniques, and actually in person is great, isn't it? And I hope that starts again soon. I think Dominic's back. We made the offer to send you to Hong Kong for the year, and we were just wondering how you'd approach that. Would you just do your technique, let everyone do uniportal, or do you think units should do the same technique?
I'm sorry, Joel. I'm not sure I could catch your question. Could you repeat?
I'm just saying that we all do celebrate different surgeons having different techniques, but I wonder if you'd think there's an advantage in a whole unit deciding the same technique. I think Alan has given a very eloquent description of saying, yes, it's great that people do whatever they like, uniportal, multiportal, but would you see any advantages to the whole unit doing the same technique? Certainly, I'd say maybe in training in your residents, also equipment, maybe. So would you think there's a strong argument for whole units deciding between multiportal and uniportal?
Well, I think there is a factor that is not considered in the publications. So when you look at the publications, you have comparison with, let's say, postoperative pain, oncological results, complications, as Alan did. There is just one factor that is omitted. It is the pleasure and the ergonomics of the surgeon. I mean, the safety feeling that you can have when you are at the patient back or seated, whatever, it's not important. But when I look at the single port, I always have the feeling that from an ergonomical point of view, it's quite tricky. The position of the surgeon is not always ergonomic. The position of the instruments also that sometimes there is some conflict. So I have no doubt that in the hands of a surgeon like Alan or whatever, someone who is mastering uniportal technique, you can reach excellent results. And I have no doubt that the results for the patient are very good and similar to multiportal. But you have also to consider the coronaries of the surgeon. I feel more comfortable with by operating with my two hands and a very good view. What do you think, Alan?
Yeah, I agree. But I have two hands too, and I have great vision. And I think, put it this way, I've met around the world so many surgeons who've gone to uniportal and have never gone back. I've yet to see anybody go the other way.
There is also another point. I'm always a little bit surprised that people who are using Uniportal, they are actually very much interested in articulated instruments, in the development of Uniportal robot. And so it seems like in the forthcoming years, they will switch from Uniportal with straight instruments to Uniportal robot, which is a totally different approach, because the Uniportal robot with articulated instruments is just operating multi-port with just a single port.
Yeah, I think of about 4 or 5 years ago, I think we were all talking about the single port robot, and the prototypes have been tried by many of us. However, I think as we've waited for so many years for this robot to come out, I think we've just given up on it, to be honest. I think the single port robot will be useful for some surgeons and some centers, but I think just like any other instrument, it's a very personal thing. And I agree with you completely that instruments are important, but there are no perfect instruments in the world. It's always a personal preference, and everybody has to try things and find the ones that suit them. For example, we have 2 different brands of staplers. I mean, you're never going to prove one stapler is better than another. It's always a matter of personal preference. And personally, I mean, I use just 4 instruments plus an energy device for all my operations. But that's just me. For another surgeon, they might like a different set of instruments, et cetera, et cetera. I think it's very personal. And it goes back to Joel's earlier point that to see surgeons around the world using different instruments, you learn from them and see, that instrument might work for me. I have no doubt that if I came to Paris and I saw your instruments in action, I would definitely steal some of your ideas and use them in Hong Kong.
I would be certainly interested in having the point of view of Joel, who is so much interested in articulated and motorized instruments.
Yeah, thanks. And just as Alan and you say, it's such a fast-moving field, and it's a really exciting time to be involved in this fast-moving field because there's so much development. So I've been using the Artisential articulated instruments, and for me, they are a step up in your ability to have wristed instrumentation. I would have to disagree with you, Alan, about the single-port robot. I'm in love with that damn thing. I went out to San Francisco and I did a subxiphoid lobectomy on both sides and a thymectomy. It was phenomenal. I got to station 7 better than I'd ever got before because it's got this incredible snake camera. And I was just talking to Daniel O, and they're just getting FDA approval to start trials in thoracics. So watch that space. I guess one question to both of you really is, I mean, we've discussed 1 port versus 3, but the current robot's 5 ports. So maybe Dominic, is 5 ports crazy? I mean, that's what a robot uses. Maybe that's too much for you as well, Dominic.
Well, yes, 5 ports is crazy. I agree. But what about 5 ports if 1, 2, or 3 of these ports are actually for micro instruments like 3 millimeter, where you don't even see the scar on the patient? So how would you call this? You will call this multiple 5 port surgery, or let's say 2 ports or 3 port surgery with additional access?
Yeah,
I think this is not important. I mean, I could operate with 7 ports if there are only tiny instruments.
yeah. I think the most important 2 words in your question, Joel, is too much. What's the definition of too much? In my book, the definition of too much is making one incision that doesn't add anything to your operation. So that was what I was talking about in my presentation about the Magical X supports. If you go to 5 ports or 6 ports, but you find that 5th port or the 6th port does add so much to your operation, that's not too much. That's fine. But if you're already using 1 port and you find that adding the 2nd port or the 3rd port doesn't add anything, then that for me is too much.
And on the other side of the whole spectrum, you've got the 5-port approach. And then, Alan, you work with Zhang Lei, who's not in the chest. He does subxiphoid only uniportal. And is that just too far in difficulty for yourself, Alan?
Well, I don't know. I've used the
Future of
subxiphoid approach, as you have, Joel.
Is it just too hard?
Yeah. No, I don't think so. It's just like we were talking about instruments. It's just another tool in the armamentarium. And it's good for surgeons in a safe environment to try that and see if it works. You'll never have subxiphoid, I think, for every operation. Even Zhang Lei, he doesn't use subxiphoid for all his operations. But it's there if he finds a case that it's appropriate for. So that's the way I look at it.
I fully agree with that, and nothing to add.
And so just winding up, maybe a question for both of you. Let's do this in 5 years' time. So in 5 years' time, I'd like both of you to tell me how you think your techniques will be different. Or tell you what, let's go for 10 years. How will your technique be different, Alan and Dominic? Starting with Alan.
Well, in 5 years' time, I'd be out of a job. All these cancers are going to be treated by immunotherapy. Or photon beams.
or endobronchial distraction.
Yeah, exactly.
And Dominic, what are you going to be doing in 5 years?
Yes, endobronchial distraction plus immunotherapy. No, I'm just kidding.
Yeah.
But
Well,
I think the future, if companies succeed, is probably single port robot. But
great. Well, with that far vision, I think we've had a great discussion. I think we should probably. Yeah.
But if we remain to, let's say, conventional thoracoscopy, I hope you have understood that multiport is the way to follow.
You're the host. I won't argue with that.
Well, perhaps we better end. Yeah, so we better give Dominic the final word there, and I do declare it a score draw in the interests of equity, but it was a really great presentation, 2 absolutely phenomenal presentations from giants of our specialty. You've both made absolutely immense contributions to our specialty, and I think hopefully you've enthused us all that the future is exciting, it is changing, and we must change with that. So thank you very much, Alan and Dominic, and I'll hand over to our sponsor from Delacroix-Chevalier, and I'd like to say my personal thanks to Delacroix, and thank you all for listening.
Thank you, Dr. Sioe, Dr. Gosso, and Dr. Dunning for this rich and insightful session. Dr. Sioe and Dr. Gosso, you have made 2 very nice presentations to explain why you prefer the surgical approach you routinely use in your expert centers. Dr. Dunning, we appreciate your accurate questions coming from both the audience and your own expertise in thoracic surgery. Referring to your questions about the future of this surgery, it shows you are always looking for new techniques and new solutions to make patients' lives even better. A special thank you for that. A big thank you also to all the attendees for your relevant questions and remarks. We had over 300 people registered. I hope it has been beneficial to each and all of you. Delacroix-Chevalier is committed to promote minimally invasive cardiothoracic surgery solutions, and I'm glad to announce that other surgical lectures will be scheduled soon. Thank you again, doctors. Thanks again for attending this event. Stay safe and see you again soon, physically, I hope. Have a nice day. Goodbye.